Chapter 2, Module number 1, focuses on the pathophysiology of pain, and it describes several of the different changes that can occur to the nociceptive system, which triggers pathological pain, a malefic consuming neurologic disease. In Chapter 1 of Module number 1, I have described, in basic, simple terms, physiological pain, a vital function which is generated by a normal nociceptive system activated only by high-intensity stimuli, and therefore it protects us from further injury. This wonderful system, however, can change due to injuries or illnesses, and from a high-threshold system it becomes a low-threshold system. In other words, innocuous stimuli of low intensity can activate this altered system. Also, injured nerves can generate spontaneous impulses without a peripheral stimulus, and therefore cause significant pain without an external component. This type of pain has lost its physiological function and must be considered a pathological pain resulting from a system that is gone awry. In other words, a neurologic disease. Pathological pain can be caused by at least 3 abnormal conditions of the nociceptive system. They are peripheral sensitization, nerve injury, and central sensitization. Let me describe them in simple terms. Returning to Fernando Cervero presentation, we see now in this slide that it describes a second phase, a phase associated with inflammation or trauma. In this condition, low-intensity stimuli activate the nociceptive system. The impulses are carried to the brain, causing significant pain, even though the stimuli are of low intensity. This condition, typical of an inflammation or trauma, is called hyperpathia, and it consists in the combinations of both allodynia and hyperalgesia. Allodynia is, by definition, the sensation of pain caused by a weak stimulus that, under normal condition, does not cause any pain. Hyperalgesia, on the other hand, is an exaggerated response to a painful stimulus. Let me try to explain why a high-threshold nociceptive system can change to a low-threshold nociceptive system. There are many different mechanisms. One of these mechanisms was described by Dr. Pert in 1976. In his study, he described the sensitization of peripheral nociceptors. In simple terms, this was the focus of his study. A peripheral nerve that, under normal conditions, reacts to high-intensity temperature was isolated, and at a certain distance on the same nerve, an apparatus capable of recording neural action potential was placed. The nerve was then stimulated by applying gradually increasing temperature. In the upper part of the slide, one can see that the stimulus in the form of temperature was increased from a baseline of 36 degrees centigrade until about 55 degrees centigrade, and then the temperature was quickly returned to baseline. On the top of the slide, we can see the normal response of these thermonociceptors, or a nociceptor that responds to high-intensity temperature. There is no action potential being generated until the temperature reaches about 45 degrees centigrade. As the temperature continues to increase toward 55 degrees centigrade, the neuronal activity increases by generating more action potential expressed by the increased number of dots. Returning the temperature to the baseline stops the activity of this nociceptor. This nociceptor, however, can be easily sensitized. In other words, can change from a high threshold to a low threshold nociceptor. This can be easily accomplished by repeating the stimulus every 300 seconds for 3 and 5 times. The results after repeating the stimulus 5 times are depicted in the bottom of the slide. Action potential are now generated at much lower temperature. Their numbers significantly increases, and after the temperature returns to baseline, there are still some action potential being generated. This is by definition a sensitized peripheral nociceptor. These are two simple examples of condition involving sensitized peripheral nociceptors. If a person suffers a sunburn, the simple touch of the shirt to the skin that has been burned causes significant pain. The hitting of a finger with a hammer or closing a door on it causes significant sensitization, that even the change from the diastolic to the systolic pressure causes severe throbbing pain. So, the peripheral sensitization can be a significant component of the perception of pain during trauma and inflammations. Professor Hermann Handwerker, a German physiologist and a leading pain researcher, described the concept of an inflammatory soup. He reported that whenever there is an inflammatory process, cells are destroyed and they release in the extracellular fluid several intracellular substances such as kinin, especially bradykinin, hydrogen and potassium ions, prostaglandin, serotonin, and lactic acid, that not only significantly lower the nociceptive thresholds, but can cause generations of nociceptors' action potentials. For instance, a patient having undergone a thoracotomy, these algogenic substances released by the cells destroyed during the surgery will cause sensitizations to the point that simple muscle activity associated with deep breathing or coughing, which are usually not painful, become very painful, up to preventing the patients from performing these basic functions. Continuing in recalling Bernardo Cervero presentation, he describes a phase 3 of pain experience, and this phase is typical of chronic or neuropathic pain. In this phase, there is intense allodynia. This slide clearly shows that patients suffering from this condition experience pain that can be triggered by even a slight touch of a feather. It lists a series of diseases that can change the nociceptive system and cause it to become so abnormal. They include arthritis, diabetic neuropathy, postherpetic neuralgia, sciatica, back pain, trigeminal neuralgia, poorly treated acute pain, just to mention some of these conditions. Non-physiological or pathological pain can also have another cause. It can result from peripheral nerve injuries. These injuries can be caused by at least 3 different mechanisms: mechanical injuries caused by trauma or surgery, chemical injuries caused by substances such as some chemotherapeutic agents to treat cancer, or diseases like diabetes that can cause diabetic neuropathies. Microbial nerve injury, as those caused by the herpes zoster virus that causes shingle and that can evolve into postherpetic neuralgia. The mechanism by which pain is triggered by an injured nerve, whatever the cause, is explained in this simple slide, where the starburst represents a nerve injury. The nerve injury can cause the development of neuromas at the injury site, with accumulations of sodium channels. This accumulation of sodium channels also occurs at the tip and all along the injured axon, as well as at the dorsal nerve root ganglia. The accumulation of sodium channels become foci of hyperexcitability and can initiate action potential independent of a peripheral stimulus, which, upon arrival to the cortex, triggers the perception of pain. The third major mechanism of pathological pain is subserved by central sensitization. This usually occurs when a barrage of nociceptive action potential reaches the dorsal horn of the spinal cord. Over time, this area of the spinal cord becomes sensitized. The result of this sensitization is that impulses that are not nociceptive, when they reach this sensitized hyperactive spinal cord, they are misinterpreted to be nociceptive impulses and are transmitted as such to the brain. In this simple drawing, we see how the barrage of nociceptive impulses originated from the limited area of trauma reach the spinal cord, which, due to neuroplasticity, over time changes and becomes sensitized. Because of these sensitizations, the peripheral area of allodynia and hyperalgesia surrounding the original trauma becomes larger. By definition, the limited hyperalgesic area surrounding the trauma is called primary hyperalgesia, while the larger area of hyperalgesia resulting from the central sensitization is defined as secondary hyperalgesia. This slide tries to further clarify the concept of central sensitization. In the upper drawing, a normally functioning A-beta proprioceptive fiber, which, when activated by a brush stimulus, causes the perceptions of a simple, non-painful touch. This stimulus is too weak to activate the firing of the nociceptive central pathways. In the lower portions of the slide, the continuous nociceptive input from the periphery to the spinal cord has caused the central sensitization, or sensitization of the spinal cord, represented by a starburst. Due to this change, an A-beta fiber weak proprioceptive action potential is now sufficient to activate the central nociceptive pathways, causing the perception of pain. The enlargement of the area of allodynia and hyperalgesia surrounding the area of trauma can be explained by the amplifications of the proprioceptive action potentials caused by the sensitized spinal cord and the resulting activations of the central nociceptive pathways. Hypothetically, another possible mechanism of augmentation of pain perception could be caused by neuroplasticity of the brain and of the cerebral sensory cortex. In the mid-70s, Morpurgo, an anesthesiologist interested in pain research, joined forces with Spinelli, a neurophysiologist interested in cerebral neuroplasticity caused by visual abnormalities. In one experiment, they studied the effect of noxious stimuli on the development of the neural sensory cortex and in 1976 published their data in the Brain Theory newsletter. In 1979, in a chapter of the book Advancement in Pain Research and Therapy, volume number 2, Morpurgo summarized the results of the study and wrote, "Kids exposed to repetitive noxious stimuli in a body part with small cortical representation have shown a dramatic change in the contralateral cortical representation as compared to the unaffected opposite side. As pain experience continued, larger and larger areas of the cortex became involved and higher number of neurons became specific to pain. A second evaluation, after several months without any pain stimuli, revealed persistent alterations of the cerebral map as recorded at the end of the training. This data suggests that at the brain level, the pain experiences produce complex mechanisms of perception involving a large number of neurons and causing an abnormal sensitivity to noxious stimuli. This study was done in young animals where neuroplasticity occurs very easily. This field of research needs to be greatly expanded. If this finding could be reproduced, especially in adult animal, and using a different model, it would help in further elucidate another mechanism of allodynia and hyperalgesia. Interesting results are being reported by imaging studies using PET scan and functional MRI. These studies showed that brains of chronic pain patients develop an alteration in their architecture when compared to brains of patients not suffering from pain. So, at the conclusion of this extremely simplified concept related to the physiology and pathophysiology of pain, we can use S to represent the stimulus intensity and R the painful response. We see in the upper portion of this slide the rendering of physiological high threshold protective nociceptive system. The first stimulus is not strong enough to activate a normal nociceptive receptor, but it can activate a proprioceptive receptor, and the result will be a sensation of touch, pressure, but not pain. As the stimulus intensity increases, nociceptive receptors will be activated and the intensity of pain will be somewhat proportional to the intensity of the stimulus. The lower part of the slide described the experience of pain in most clinical settings or the response of a pathological nociceptive system. In this situation, now the same low-intensity stimulus can activate the altered sensitized nociceptive system and induce the sensation of pain, which in this condition is called allodynia. Allodynia is defined as the sensation of pain caused by a stimulus that under normal condition is not painful. As the stimulus intensity increases, there is an exaggerated response to the painful stimuli, which is defined as hyperalgesia. The question now is, should clinical pain, which includes chronic pain as well as acute, inflammatory, post-traumatic, post-surgical pain, be considered a disease? The medical definition of a disease is a condition of abnormal vital function involving any structure, parts, or system of an organism. Indeed, clinical or pathological pain is a disease. When a patient experiences post-traumatic, post-surgical, inflammatory, or chronic pain, This is the result of a significant alterations that have occurred to the physiological, protective, high-threshold nociceptive system. In its altered state, it can be activated due to peripheral sensitization by low-threshold stimuli. Nerve injury can generate nociceptive impulses without peripheral noxious stimuli. Central sensitization may convert proprioceptive action potential carried by A beta fibers to impulses able to activate nociceptive pathways. Therefore, clinical pain is a neurologic disease, with acute pain being mostly a reversible disease, while chronic pain being mostly an unreversible disease. This is not a new idea. George Washington Cryle, a surgeon born in Ohio and a founder of the Cleveland Clinic, 100 years ago hypothesized that pain was a disease, as he wrote.
The lesion, which produces a painful scar, is in the brain, not at the site of the wound. A strong traumatic or psychic stimulus produces some changes in the conductivity somewhere in its cerebral arc, the effect of which is to lower the threshold of that arc, and hence from that time on, mere trifles become adequate stimuli.
Dr. Cryle had the remarkable ability of deducing from recurring clinical observations major medical concepts. It is very interesting that he not only believed that the strong traumatic stimulus could lower the threshold of the cerebral arc, which has been extensively proven, but that also strong emotional stimuli could produce similar results. Several concepts and observations reported in these presentations could validate Dr. Cryle's hypothesis. First, we know that pain has both a physical and emotional component. Second, the removal of the emotional component in the lobotomized patient removed the suffering from the physical pain experience and made even severe pain non-bothersome. Third, neuroplasticity is a property of the nervous system. This function is widely observed in the nociceptive system at the peripheral and spinal cord level. There are limited evidences that neuroplasticity can also occur at the somatosensory cortical level. It can be deduced that due to neuroplasticity, exposure to strong emotional stimuli such as child abuse and abandonment, spouse abuse, fear of death, continuous unrelenting severe physical pain, just to mention a few situations, could cause abnormal neurodevelopment and neural connections of the emotional part of the brain, such as the limbic system. This augmented development and hyperactivity of the emotional centers of the brain could trigger an exaggerated emotional response to a nociceptive stimulus of low intensity. This low-intensity stimulus, as hypothesized by Dr. Cryle, because of the exaggerated emotional response, will be perceived and reported as a response to severe physical nociceptive stimulus. The pain report is based on the normal and abnormal functions of two systems, the physical nociceptive system and the emotional system, which leads to 4 different conditions with a myriad of possible responses due to the degree of abnormalities when they are present in each of these two systems. The 4 basic conditions are: both the nociceptive and the emotional systems are normal, an abnormal nociceptive system and a normal emotional system, a normal nociceptive system and an abnormal emotional system, and both the nociceptive and emotional systems are abnormal. This is a field of study that has received little attention and needs further evaluations and awareness. In summary, nociception and its cortical expression, pain, are activities of the nervous system. The physiological function of the nociceptive system is to be a high-threshold, protective, warning vital function. However, due to injury or disease, this system can change and can misfunction. In this altered state, it loses its physiological function and becomes pathological, and at this point, pain becomes a disease. In fact, this altered system is now activated by low-intensity, innocuous stimuli because of peripheral or central sensitization. Furthermore, due to peripheral or central nervous system damage, it can even self-generate nociception impulses, therefore completely avoiding the need of the input from the peripheral nerve receptors. Therefore, the goal of pain therapy is not to abolish the sensation of pain. The goal is to return an abnormal hyperactive system toward normalcy. Module number 2 of Milestone in Algology will focus on the incidence and deleterious effect of both acute and chronic pain, as well as to show the importance of individualized or personalized pain therapy.